Today I'm dedicating this talk to Dr. Palande for the simple reason that he's the man who encouraged me when I presented my work of 8 radial club bands and 3 polysciasis to him in Manipal. From Tamil Nadu, he has sent quite a few cases to me. Each radial club band is different. Management is a challenge as no one method is totally perfectly right. We have to know certain things because 2/3 of are associated with systemic musculoskeletal anomalies. 1/3 of them have syndromic presentations. So these patients have to be evaluated properly, and some of them may not be fit for any surgery. Many syndromic things which I have enumerated here, but one should also think in terms of a detailed study of the child by a pediatrician. As far as we are concerned, locally we have to examine clinically how severe the deformity is. Radiographs of the upper limb, the hand, the spine, lower limbs are to be taken. And most important, clinically, we should check the elbow movement. Systemic evaluation, ultrasonography of the abdomen, especially to look at the kidneys functioning, kidney, and heart 2D echo, because often the hand anomalies are associated with the cardiac anomalies. Blood investigations, in particular platelet, because thrombocytopenia is not uncommon, and chromosomal challenge test preferably has to be done. Many classifications are available, but Bain classification is from practical point of view, it's more important. In type 1 and 2, outcome is comparatively favorable, but in type 3 and 4 are very unpredictable. Other classifications I'm not going to talk to. 3 important questions we must ask ourselves before managing a case of radial club hand. Is surgery worthwhile? Will surgery cause further shortening of ulna? Does deformity correction yield better function? Our aim of the treatment is align the hand with the axis of the forearm, correct the radial bow, preserve the limb length, and we should optimize the hand function as well as the thumb function. The contraindications, of course, are when the elbow is totally stiff, because in such a case, if we do any correction of the wrist and the child's hand cannot be brought neither to the mouth nor to the perineum, so the treatment will be a disaster. That's what Lambert suggested. So as we are concerned, when the child is brought initially, we do what's called serial plasterings, 0 to 1 years, soft tissue distractions and realignment, and radialization, and sometimes centralization as the case may be. On the contrary, between 1 and 10 years, we do, in fact, polysciasis is the time when I do usually put up by about 1 year or 1.5 years, or openness plasty if required, because thumb function has to be regained very soon. If there is recurrence also, we operate them between 1 and 10 years, and then the surgery that we do is centralization instead of radialization. About 10 years, of course, we consider surgery as far as distraction of the forearm bone for lengthening, or lastly, ulnocarpal fusion. Type 1 and 2 are more amenable to treatment. We do the stretching and splinting initially, later probably soft tissue release if required, and tendon transfers. And if it is type 1, lengthening of the radius. In type 3 and 4, we do radialization in younger children, and slightly bigger children, we do centralization. Thumb openness plasty and polysciasis is done usually in the first year, and lengthening of the radius after the child is about 8 to 10 years. The Wilkie's procedure is also described in type 4, but we have no experience. 0 to 1 year age group. Lamb was the one who popularized centralization in 1977. He said he would do a soft tissue release and centralize by creating a notch in the carpal bones and centering on the 3rd metatarsal. He did not recommend any tendon transfers. Watson and Bain and Klug modified his procedure, and they advocated ulnocarpal realignment and tendon transfers. However, centralization, the problems is recurrence rate is very high compared to radialization. Long-term results are resulting in shortening and limited wrist motion. So in 1985, Jitterbug Gramco suggested a thing called radialization, where he said soft tissue release can be done, and radialization of the carpal corpus on the ulna is overcorrection of the deformity so that the head of the ulna will be aligned with the second metacarpal. Along with this, he would do flexor carpi radialis and extensor carpi radialis transfer the extensor carpi ulnaris, so that the forces are acting more on the ulnar side. A diagrammatic representation of the same. Radialization does not involve any excision of the carpal bones. It maintains the limb length and improved wrist motion. Both in centralization and radialization, our principles are pre-centralization of soft tissue and stretching, realignment of carpals on the ulna, tendon transfers, and are correcting the ulnar bow. One example where initially stretch the wrist with external fixator. Earlier we were using the longitudinal incision and sometimes transverse incisions. It is mild. However, we have given up these days because of the problems. Especially in severe cases for correction, it's advanced bilobed incision has given us good results. Though we have said that the extensor carpi release, we don't release it in all cases, but if it is often lengthened, we shorten the extensor carpi ulnaris. We reflect the extensor retinaculum and expose the extensor tendons. And one may recognize an analog, cartilage analog of the radius. If it is present, we have to excise it. Most important thing is to identify the median nerve, because often it is right at the base of the index finger alignment. It's more on the lateral side, and one may damage it and mistake it for a tendon. Release the radial wrist extensors so that we can transfer it subsequently onto the ulnar side. Adequate release of the ulnocarpal joint is done, and hand is realigned, and a K-wire is passed from the ulna onto the second metacarpal. After stabilizing the wrist, tendon transfers are done. Radial wrist extensor to extensor carpi ulnaris. If extensor carpi ulnaris is lax, one can shorten it. This is a post-operative picture. There's a K-wire, not exactly going through the second metacarpal, but between the second metacarpal and third metacarpal. Post-operative splinting is very much required for long periods, otherwise recurrence rates are quite high. It's just follow-up 1 year in a child. In fact, this has been published in the Journal of Hand Surgery, which I'm sure that all of you could go through, and our short-term about 5-year follow-up of 20 limbs. This is an example of 18-year follow-up, 16-year follow-up in a girl, Bindu. Of course, initial complications with the curvilinear incision was this necrosis of the skin. Recurrence and shortening is also very common. Recurrence here and shortening. Premature fusion of the epiphysis sometimes. I'm not going to elaborate on this slide because time is quite short. It's allotted to me as 8 minutes. It's available. Murphy's paper is available for you to know which is better. In 1 to 10 years age group, of course, problems of recurrence is very common. And early part, we do polysization and opponentsplasty. And later, 10 years later, we do distraction lengthening of the radius. Polysization, in fact, if radialization is done, I usually do 2 months later the polysization. Opponentsplasty, we do a ABCD flap release, collateral ligament reconstruction of the on the ulnar side, and Huber's transfer, classically about which Dr. Mukund Thatte has already talked to you about. And lengthening is required. In fact, not that in every case we do it, but if the patient desires it, when they come and ask for it, definitely we will think about it. Osseous distraction lengthening is recommended. Mature older children and good family support who have realistic expectations and emotional stamina, because we cannot guarantee, because complications are quite a bit. We can achieve about 4 to 8 centimeter lengthening can be done. Stage procedure to be done in about 3 to 4 times, and patients as well as the parents must have the patience to look into the problems. Complications, pin track infection, poor regenerate, stiffness, etc. are very common. One example of distraction lengthening. The length needs so much. and it's producing slight deformity at the wrist joint, more of flexion, and finger stiffness, etc. are very common. Pitfalls with the lengthening are need for multi-stage lengthening, complications encountered invariably, which include stiffness and recurrence of the deformity, pin track infection, delayed union, and pain. Marked growth retardation of the bone after lengthening, particularly after the second stage, and literature have not shown that there is improved function of the upper limb. We have no experience with this procedure. Wilkie claims that the deformity correction is very good and movements are better. In summary, is a commonest of the upper limb longitudinal deficiencies that we see. Associations with other systemic anomalies are very common, syndromic. Both centralization and radiation are having benefits in type 3 and 4 defects. Lengthening of the forearm can be achieved. Pitfalls are that recurrence rates are still high with centralization and radialization. Complications of lengthening, suboptimal function with radialization and centralization. I just want you to look at this beautiful girl who was the first patient of mine by the name of Sana, who got married, of course, later. She had radial club hand on one side with no thumb. We have done radialization as well as polymerization. And she worked as a OT assistant till the age of 30 years. And she was an asthmatic. Unfortunately, she died about a few months ago. Thank you very much.